What's it like being a medical student now?
To sum it up in one word, it would be demotivating. It's probably the main way I described it. I didn't realize the idea of a portfolio career even existed. I think in my mind it was either you were a full-time clinical doctor or you weren't, and there was nothing in between. And from my experiences at the time, I thought there was going to be the latter for me. But having worked in the health tech space for the last few years and seeing a lot of really fantastic role models who balance their clinical career with health tech, with leadership, with research, and like 20 other different things, that really shown me a different path to just be a medical doctor or just be in industry.
Hey everybody, this week I'm joined by Tom, who is a freshly graduated doctor from very, very, very recent medical school finish. Co-founding his own startup, doing loads of cool stuff. Anyway, Tom, we'll chat about it. How you doing, man?
I'm very good, James. Thank you very much. Very excited to be here.
You're very welcome. You're very welcome. Yeah, it's good to have a breadth of people on this to stay to stay grounded. Because basically, it's funny, isn't it? Medical students get talked about a lot, and actually something I'll come on to talking about is my next generation community that I'm setting up for this exact reason. That I think medical students, F1s, F2s, you get talked about a lot as people in your career, and I've just worried for a long time that people early in their career don't have a huge voice, and I think an industry can only really stay moving forwards if we actually listen to people. So like, rather than just reading, a study of 90 medical students and 85 of them are thinking of leaving, why don't we actually talk to one of them? So here you are. So Tom, listen, it'd be good to just chat, man. Like, tell me your story so far. Obviously you're early in your career. I know that we've met through some of the BMJ stuff that you're doing, their BMJ Future Health event for, like, I guess, people that are interested in health tech that have a hand in medicine or a growing interest in digital health and that kind of thing. We've met through some of the stuff you're doing for that. You've got other stuff going on, but yeah, man, tell me the story.
Yeah, thank you very much. That's a very good intro. So like James said, I'm a recent medical graduate currently working as an F1 here at St. Thomas's Hospital here in London. So I graduated just half a year ago now. Feels much longer than that, but yeah.
Time flies, dude, honestly.
Yeah, it's only been half a year, yeah. So throughout medical school, I've always enjoyed doing stuff alongside my clinical practice, whether that's research, teaching, or what I've been most heavily involved in, which is the health tech stuff. In terms of, I think I definitely fitted into that analogy of those 85 who wanted to leave medicine
Really?
As soon as they graduated, probably a few years ago. But I'm happy to say that my career plans have changed since then for quite a variety of reasons.
Let's just talk about that before you move on then. So what's it like being a medical student now? And maybe think about a few years ago when you said, you've gone from a place of wanting to leave to no longer wanting to leave, because there's technology, there's AI, there's workforce pressures that must, everyone's complaining about being a medic, and so how does that affect medical students? Like, where it obviously made you want to leave, like, how's that changed now? Like, tell me about that stuff.
Yeah, I think to sum it up in one word, it would be demotivating. It's probably the main way I described it.
That's probably quite a diplomatic way of putting it.
Yeah. There's definitely a lot
really
of other words.
Effing annoying is probably another way of putting it.
Effing annoying, depressing, yeah, all of the above. But yeah, I think from my own story, I think I probably started having second thoughts around the start of third year of medical school. Okay. So that's the first year for us where we had clinical placements.
Yeah.
The 2 years before then, we had pretty much all lectures on the basic sciences, the anatomy, tons and tons of question banks of multiple choice questions, which, to be honest, I actually really enjoyed learning most of it. I think I really like science, and that's why I went into medicine. So I found that most of the stuff I learned about really fascinating. But then when we actually started clinical placements, I think there was such a stark contrast between what we were learning and what junior doctors do will junior doctors spend 90% of their day doing, which, for the lack of a better phrase, just seemed like mindless admin. Whether it was like
slicing it,
whether it was
it's two completely different things. Utterly.
And it was just driving on ward rounds, doing discharge summaries, and like spending hours and hours using the hospital IT system. And everyone on all the junior doctors I spoke to around the time were like, I don't really know what I was studying for or why I spent all that time studying for, because I don't feel like I'm using my clinical knowledge. I think that really put the thought in my mind whether clinical medicine is a career for me. Obviously, things, as you get more senior, you get more responsibility, you use that clinical stuff a lot more, but the first 2 years, at least 2 years, you're not really using much of that at all. And then all of that combined with the other stuff we hear around medicine, things that are a lot more prominent now, but started cropping up back then already, whether it's the training bottleneck, people being stuck in foundation years or being stuck in registrars for years, whether it's the lack of certainty as to where you're going to be during your training and constantly having to move around. So you're not...
Which, by the way, is a lot worse now, right?
Yeah, it really
is. It's an actual lottery.
Yeah, it is. I just missed out by that for 1 year, which I'm incredibly grateful for.
Just tell people about this system, because I heard this from Faith Lee, actually, when she was saying that she's going through it and stuff, that like... Yeah, I actually didn't know it was such a lottery until that point that it changed. Because when I did it, you'd fill in white box answers and you'd get a score based on those, which is remarkable that's how it worked. Yeah, you'd fill in white box or white space answers, whatever you call them, and then which were just sort of like a strange like vignette type stuff, and then. Yeah, you'd get a score based on that, and based on that score, you'd then get your ranking of deanery, it was at the time, I think, or region.
Right.
And obviously, if you were super bold, you'd pick London, and then just hope you got it, because if you didn't get your first choice, you were then going to end up in one of the areas that needed more clinicians, basically, rather than that you wanted. So, yeah, in my day, it was like... Are you going to put London, yes or no? Like, are you going to go for it? And like, even within that, are you going to put South London? Because I remember applying for pediatrics at the time, which was something I did. I don't think I told that story, but yeah, once upon a time, I actually applied to do pediatrics, and it was like, do you put South London or do you put North London? Because like South London's like, that's the baller move.
The fancy one. Yeah.
Or was it North? I think it might have been North actually at the time, but anyway, one of them was. But yeah, anyway, how's it for what's it like now? Because it's even worse now.
Yeah, so it's interesting that you mentioned the white space question, because I think we're 2 generations past that now. I think
wow.
The previous,
showing my age.
I think the previous one, so it's changed a lot in the last few years. The previous one, probably if you graduated in 2023, 2022, it was, you were scored out of 100. I think you got 40 just for going to medical school, and then another 10... And then another 10 based on what decile you placed in the medical school. So if you were top decile, so top 10% of your medical school, you got 50 points.
Yeah, we had that in ours.
Yeah, and then the other 50 points came from the situational judgment test, which...
Oh, the SJT, yeah. About this.
Yeah, and then everyone has their own thoughts about the SJT, whether that's a lottery to begin with. And for my year, we got rid of the SJT, so we had either the academic foundation program or the normal foundation program. And the normal foundation program was completely randomized. So you just ranked all of the deaneries, so 20 deaneries, and if you're feeling lucky, you put London first. Or you're not feeling lucky, you try and game the system a little bit, you look at the competition ratios and like...
This is it, yeah. Oh my God.
And that's the 2 years of your life deciding based on a lottery and not by anything that you've done leading up to this, which...
It's amazing, isn't it? It's amazing that you wonder why we have a workforce crisis when the way that you treat your workforce... And just to put this into perspective, for anyone that didn't actually do medicine, can you imagine as you're sitting there right now in your car, on the train, on the way to work, imagine that you are now a third-year university grad and you are finishing university, you're thinking about where you want to start your life.
Yeah.
And what your job says to you is, oh, by the way, just write your name on a piece of paper and stick it in this hat. Then we're just going to call out some random cities in the country.
Yeah.
And if we pull your name out, that's where you're moving to do this job. You'd be like, I'm just going to do a different job. However, medicine, wonderful, has absolutely kneecapped you because medicine is now the only thing you can do, basically, because now you're just in this system. That is what you're doing, I'm afraid. So that is the situation that you're in. It is bananas. That we have got a system that does this. I
think being in medicine, you just sort of accept it, like, oh, this is what's going to be.
You do, don't you?
There's no alternative. So you just say, yep, fine, I'll take my pick of the lottery and see where I end up. But I don't want to go on complaining about it too much. I think there's a lot of criticism about the system, but it's difficult to get right when you're trying to place 10,000 people across the country.
It is. The US system's interesting, isn't it? Because don't they the hospitals train the interns and then they select from those interns, or I think there's maybe another way that they do it, but I know there's a lot more sort of hospital loyalty, I guess. So if you've impressed the consultants there or the attendings there, that they're empowered to then give you a job, or at least that's how it works in Scrubs anyway. when Turk and JD end up in the same hospital for so long.
The documentary Scrubs,
absolutely. The basically a documentary of Scrubs. Amazing.
One other thing that's changed since I've left is in the couple of months since I've left is they've actually changed the academic program as well. So the only reason I got into London is because I interviewed for the academic program where you had to have a set number of publications, posters, things like that. And then if you pass the interview, then you actually know where you're going to end up for the next 2 years. But then since I've left, they've pretty much gotten rid of that as well. So you can be someone who's never had any interest in research, but you get randomly allocated into a research program. Whereas people who have spent their whole medical career doing research, they want to do it, and then they get allocated to the normal program, which just completely baffles me.
Yeah, I'm laughing, but it's just ridiculous, isn't it? I do just want to say though, like you wonder why we have a workforce crisis. You wonder why the workforce is demotivated, as you put it.
Yeah.
Or however else we've put it in that conversation. You wonder why, when your career starts like this, how valued can you possibly feel? Like how you've got to uproot. What if you've got a family? What if you've got like kids? Like what if you've got, it's frankly, you just want to live somewhere where all your friends live because it will make you happy. It sucks. But anyway, so that's one thing. We could do a whole podcast on that, but that's when you wanted to leave. But then obviously you've started working and all the rest of it, and how's that changed? What's the first 6 months like been on the wards for people that maybe haven't done medicine or understand?
I'm currently at St. Thomas's Hospital, which is a really big hospital in London. So my experience is probably not very reflective of what most of the fresh graduates feel. But I think...
Why do you think that is? Is that just because you're more supported there than other places?
I think protected is probably
interesting.
It's probably the better word. In both the good and bad sense. I think the good sense being like you always have someone you can ask for help from if you feel like you need it, which, to be honest, is all of the time when you just graduated. Even like I remember I started on night shifts as my first shift out of medical school. So and then I didn't even know, like I wouldn't even feel comfortable prescribing some basic fluids for a surgical patient.
I remember.
Message my house officer in the middle of the night, be like, can I prescribe this fluid? And they're like, yes, obviously.
But it's true though, man. Like no. Like I think this is worth talking about. I think that moment where you prescribe another human, frankly, a drug, fluids, like you're putting a litre of fluid into someone's vein for the first time, or at least you're signing off that is okay. I can remember the first time I did it. So when I first did it, I can remember I prescribed it. I was in a rural DGH, so like district general. This was not a well supported role.
So very different experiences.
So you just had the nurse saying, prescribe fluids, please put it here. And you're like, saline, Hartman's?
Yeah.
They're like, literally, just put any random word in this box and sign it. I'll sort it. You're like, okay. And then I literally checked on this guy probably every 4 minutes for 6 hours to check that he wasn't like coughing or choking or drowning to death, or that he had undiagnosed like end stage heart failure, and all of a sudden I'd like ruined him and like killed it. Like I was honestly, like genuinely, like petrified.
Yeah.
And I can remember also, funny, I don't know what it was like for the first time that you prescribed a drug, but I remember the nurse, they're like an actual like pill. This nurse came over to me and was like, patient in bed, blah, has got a headache. Can you just prescribe some paracetamol? I was literally just looking around like, can
I?
I was like, what is it? You got liver failure?
Yeah.
Like, the nurse was like, he's not got liver failure. Like, just prescribe some paracetamol. It's paracetamol. And I was like, I don't want to please just prescribe paracetamol. I was like, I need to go see him and ask him a load of questions. And I'm like, are you okay? Have you got liver failure?
Oh my god, yeah.
Oh god, it's a huge moment. It's a huge moment.
Yeah, I remember very, very vividly. It's that same appearance with paracetamol. I think one thing that I was really thankful for is that we have a electronic medical record. So just before I prescribe any drug, I just start typing heart failure, liver failure, anything, like just going through the whole BNF list of contraindications for like the most basic drug. And like, I spent 30 minutes prescribing this paracetamol. What have I accomplished?
Oh.
But yeah, thankfully to say I've moved on. I'm more confident now. Still, yeah, only takes me 5 minutes now. But
yeah, I only ask about the top 40 contraindications now. Like it's that easy. But yeah, it's interesting, isn't it? When you start to gain confidence, it happens super quickly, doesn't it? I noticed anyway that it happened really fast. And you look after your first job, you're 3-4 months in, and all of a sudden you're like, whoa! Now I like fly into the wards and throw my coat onto the coat hanger and like grab all the drug charts and do all the things. You feel like you're in a bit of flow state, like eventually, and it all starts to like click, right?
You do. And just reflecting back on what I said earlier, like even though when I was a medical student, you see people just doing board rounds or doing discharge letters, you think like, oh, you're not actually using your clinical knowledge. But once you actually start doing the job, obviously there's a lot of time where you're not thinking much, but then there are moments where this drug is on this patient's chart and then they deteriorated, and you have to try and figure out what's causing this. And then you still, I think what I really liked about the protecting environment is like, whenever you're uncertain, there is someone you can ask about. There's someone you can ask who's like, and they're most of the time they've been all very, very supportive. They acknowledge that this is your F1 year, and they help walk you through what your thought process, and they actually teach you in the meantime. I think that's the thing that I'm really grateful for.
There is a flip side to it, I guess, and it's interesting because I don't think it's a particularly valid argument, but when I can remember there's always the people that come along and they're like, but back in my day, and then they just glamorize some absolutely horrendous thing. But a lot of the time it's like, well, back in my day, I had to treat blah blah blah, and I just had to do blah blah blah. I just had to get on with it, and some people died, and like it was fine, like, but we just did blah, and we just learned so quickly. You lot these days, you're so wrapped in cotton wool, you don't really know anything. It's like, well, first of all, that's not my fault. Like I'm part of this generation, and this was the way that I did things. And also, like, you just said some people died and whatever. Like, are you joking? Like, of course we need to sharpen our processes and do things. I think there is a there's an interesting split there between what we said about, being at Guy's and Tommy's is probably very different to being like in a super rural DGH in the middle of absolutely nowhere, in that there is going to be more that you have to do, and that confidence thing about, I can remember very early on, I think first week or first couple of weeks, just going to see someone with fast AF. So for non-medics, atrial of your heart are just fibrillating, so they're instead of beating, it's just sort of like shaking, and it's not effectively pumping blood through the heart, and it's fine because your ventricles are still pumping to a point. Eventually things will get tired and your blood pressure starts to drop, and then it starts to become a bit more problematic. But fast AF isn't too much of an emergency until it's an emergency. But I can remember going to see fast AF in my first couple of weeks and being like, oh, I've read about this. That's atrial fibrillation, and his heart's going quite fast. That's probably fast AF. And then you just get that feeling of like panic, of like, oh, I'm now going to assume the absolute worst. He's going to drop his blood pressure in the next 5 seconds, and I'm not going to know what to do, and I'm going to have to pull the, push the crash bleep, and like, I'm going to have to do all this stuff, and it's all just like, blah, blah, blah. But then because you're not supported, you have to actually think about that stuff and go, okay, hold on a minute. There is a protocol for this. There are guidelines on this. Let me follow those guidelines. I'm going to ask once I know what to do, because I know that if I call the registrar and I've not done anything, they're going to absolutely bollock me, frankly. So, and I certainly can't call cardiology, because that will be the end of my career. So my very short career. So actually, do you know what? I'm going to have to just do something. So you end up like doing your ABC and like, checking their blood pressure and making sure of this and doing the blah and I can remember doing it and then just feeling this amazing sense of satisfaction that actually I sort of do know what to do here. And I think that is sort of the advantage of being in that less supported environment. I just don't think that argument stands up though when it's like, I was the first one to a crash call 4 times in a row, or like you know what I mean, which probably nobody crashes on the wards in Guy's and St Tommy's, because actually they're very good at preventing those things, which is actually the way it should be. All that sort of stuff. So I can definitely see both sides. But you must have had colleagues like that have been in those less supportive environments versus what you were in. Like what do you hear from them?
Horror stories, to be honest. It's
really,
probably
even
the only
now,
way I would describe that. I think
nothing changes.
I think I've heard people who just started the first day on the ward and there's no consultant, there's no regis, they're just doing ward rounds. 2 fresh F1s out doing a whole ward round by themselves. I think that thought just terrifies me.
Initiation by fire.
Definitely. And part of it, like you said, you do get a lot more confident that way. Like I definitely felt a lot more confident starting on night shifts than going back to the normal wards. It was like, I've done all of this 10 times already during my night shift. I'm not asking my registrar every little thing. But that initial panic is still panic. It's not a good feeling.
Yeah, I can remember, it's like story time this. I can remember like someone needed like an ascitic drain. So someone that was in liver failure had an ascites, which is like a load of fluid in the abdomen, and just needed some of that fluid drained. And I got there, I was like, I've never done this before, so I'm going to call the registrar. So it's just like, literally just stick a needle in and pull it. And I was like, I just don't, he was like, dude, honestly, just stick a needle in and push it. I'm like, is this good clinical care? Like, is this right in a well-developed Western country that we're doing this? Like, is that a thing? But then at the same time, I think the other, to sort of play devil's advocate a little bit, I think there's a lot that's baked in my story anyway, there's a lot baked into that, which is like, he knew the patient. He knew that this was not some horribly honeycomb loculated ascites. He knows that this is one massive compartment that is impossible to miss. He knows that there's no way of hitting a nerve or an artery or whatever. Like he knows that I've got a baseline of a competence score, worked with him for 3 months. He know, like in that scenario, it's interesting because I think there's a lot to learn in medicine, isn't there? And I think you need to be pushed. If you operated in your comfort zone all the time as a medic, you would get absolutely nowhere, because it is frankly petrifying to do things to another human being knowing that it affects their health. Like it can be honestly paralyzing. And actually, do you know what, mate? Now that I've left and I think about some of the stuff, I get so much more emotional now thinking about health of people and all this sort of stuff. I remember like that I was walking around like one of National Trust places like the other day, and this like get emotional think about it, like this lady just fell over in front of me and broke her hip.
Oh my god!
It turns out she had, I mean, you could tell it was like shortened, it was rotated, it was all the stuff that I can remember, like, okay, this is quite bad, like, but she was fine. It was not like other than that. But it turns out she was telling me that she had Parkinson's disease and she needed to take her medications, and is that okay? And then I was like holding her hand, like waiting for the ambulance to come, and like, kind of gets me. But like she was saying like, oh god, like I look in the mirror now and I can't believe how old I am, and all this sort of stuff. As a medic, right, that wouldn't have been like, you're just completely dissociated. Like I've had people grab me in A&E and like all this sort of stuff because they're in pain, and like when you're a doctor you're so focused on the job at hand. Whereas like this just utterly broke me, and frankly like she was relatively young, was broken hip, she'd probably recover absolutely fine. Like actually it was fine, but like I was just in pieces. Like since leaving medicine, like the gravity of the stuff that we used to do has really started to hit me of like, Christ, like, but it's so good how medicine teaches you to like not be that, and it does push you, and it does do all of these things. But and it's interesting how I imagine it's well, you said like all that stuff eventually starts gripping you, and you start to really want to do it, and it starts to become good, right?
I think just reflecting on that story, like what you said about being in medicine, you almost become desensitized to all of this. I think that's a feeling that's actually really terrified me recently, because
interesting.
I think there's a lot of factors to it, but there's times when I almost stop seeing patients as people, but rather as problems to be solved. And
I hear you.
When like on a busy day, when you've finished your ward round at 2 p.m. and you've got a ton of jobs to do for every single patient, like anything that slows you down, like even if it's a patient saying they're in pain or there is complaining about a new problem, you sort of it's easy to get frustrated at a patient for coming to you now, and then you're just like, just let me get on with prescribing this medication. But I think, and then you stop even trying to solve the problem well. You just solve it good enough until the consultant comes see them the next morning.
That's such a I mean, thank you for being so honest there. I think that's probably really helpful for a lot of people to hear, because I think that's an indictment on the standard of care that we're able to give based on the current resourcing that we have. I think that's the biggest reason that we should all just be trying to improve the system, no matter how like that you'll ever hear. Because I completely agree with you. One of the reasons that I left is because I was a worrier, and I was so frustrated and scared that I couldn't deliver the standard of care that I wanted to deliver. That it used to keep me up at night, and that's not me being grandiose. That's an actual fact that I would wake up in the night and bleep the on-call. To be like, I think I've forgotten to do this. Like it's. Oh man, I hear you is all I say, and you're definitely not alone in that. And I also really understand that feeling of like, who even am I anymore if I just am annoyed that a patient has cried out in pain? Or I've been bleeped by the nurse because blah in bed 4 needs prescribing some more Oromorph or whatever. And it's a weird flip side that like you also kind of need that to just get through the day. Because if you don't have that to get through the day, like you'd end up spending hours with everyone just listening to their stories and trying to make them feel better. Like, and it's such an I find that really interesting. What I would say though is, as you get more senior, I think you can lean into that stuff a little bit more. I think as a junior it's tough. If you're an F1 on ward cover, Jesus, like you just got to get through the day, man. You just got to get through that list. You just got to get through that list. I think it does get a bit easier as you get a bit more senior.
And that's really, really reassuring to hear you say that. I think, like, I was starting to, having had quite a few of these experiences, I was starting to feel like if being I was starting to think of whether like being being a clinical doctor is actually right for me. But I completely agree with what you say. Like being more senior, you take on more responsibility for the people that you're caring for, and you actually want to do well for them, which I've definitely seen in my seniors as well. So yeah, that's reassuring.
And you do, and I think as you get more senior, man, as well, it's a lot more things are in your power to change, because I think you can be the doctor that you want to be, with slightly less to do.
Yeah,
and I'm not saying, by the way, I am not saying that again. The med reg on call has not that much to do. That is not what I'm saying. But what I am saying is that the neurology reg on call, or the neurology reg on a normal day probably doesn't have as much to do, but can actually go more complex and deeply into their patients and that kind of thing.
Yeah.
Particularly the consultant, maybe not the reg job, definitely the consultant.
Yeah.
So I think that's when you can really start to lean into who you want to be as a doctor. But you're not alone, man. Like this sort of stuff, these sorts of thoughts. They plague most people, because I think everyone goes into medicine wanting to help, and then you undergo this metamorphosis of like, I actually don't even want to help anymore. I just want to get through the day. I know that by proxy I'm sort of helping, and then you have a bit of an identity crisis. And I think it's reserved for the people that are introspective. And if you are introspective, I think you are going to ask yourselves those questions and check in with yourself. But I think it's super important that you do that. I think that just makes you human, dude. Like, it'll make you a really good doctor down the line. And it's good to know that you don't want to leave anymore. So I imagine though, with an interest in technology and all these problems and stuff, like you probably see a route for yourself through medicine of making change. So where are you at now, like with how you feel about being a medic, interested in health tech, like you've got a startup that you're doing with other clinicians, like tell me about like the situation you're in now, the things that you've got going on, and sort of what's motivating you.
Yeah, of course. I think just to backtrack a little bit, I think back during third year, when I thought about leaving medicine to begin with, it's a bit part of it was because I didn't realize the idea of a portfolio career even existed.
Interesting.
I think in my mind, it was either you were a full-time clinical doctor or you weren't. And there was nothing in between. And from my experiences at the time, I thought there was going to be the latter for me. But having worked broadly speaking, worked in the health tech space for the last few years, and seeing a lot of really fantastic role models who balance their clinical career with health tech, with leadership, with research, and like 20 other different things. I have no idea how they do it. But all of these people, like that mindset shifts really helps as well. Knowing that, and all of these people, they really enjoy their work. You can tell that not just from the way they speak about it, but from like how much passion they exude in each of the different aspects. And it's a lot of effort trying to balance all of these. And it's conscious effort, which you're not going to make if you don't enjoy what you're doing. So seeing that really showed me a different path to just be a medical doctor or just be in industry. So I think having that...
And most of the battle is believing it's possible, by the way, as well.
Yeah. Having that mindset shift, knowing that it's even a possibility, has definitely helps a lot. But as to what I'm doing now, so I'm working full-time as a junior doctor. Outside of that, my main focus is probably building the startup with a few other clinicians. I think we've been going for a few months now, and that's probably the thing that probably excites me the most. But outside of that, also trying to do some research, some teaching. But yeah, I'm really enjoying the variety at the moment. And I can't imagine just focusing on one thing.
I love that, man. I think that's really great. How much time do you have? So as an F1, are you basically 9 to 5? Are you protected as an F1 into that sort of structure, which then gives you the opportunity to do all this stuff for a year?
9 to 5, well, it varies a lot depending on what department you're in. So I started in rheumatology, which was basically a 9 to 5 with the occasional evenings, weekends, and pools. And now I'm on vascular surgery, so it's more like 10-hour days, and then
until surgery finishes.
But then the subsequent ward round
finishes. Yeah.
But then we do have some more off days to make up for it. So you are sort of protected into like a 45-hour working week in a hospital, thankfully.
Interesting.
Yeah, so
that's good.
Yeah,
that's good. And then it's a great age and a great time to then be doing lots of things and experimenting to see what you like. I think that's so important. Is that shared amongst all of your F1s, or I guess there's some people who just love the medicine, right, which is the absolute dream.
Yeah.
So they don't need to waste their time with all of this stuff.
I think.
Is that the general thing? Are most people trying to spread their bets and do lots of stuff?
I think more and more so, definitely. It's pretty much most of the F1s I've spoken with are thinking about doing less than full time once.
That's interesting.
Do you think that's a new thing?
Most people less than full time, you said?
From the perspective? Yeah, from the most of the people I've spoken with, definitely, yeah.
That's a very new thing.
Oh.
Well, it's certainly newer than when I was doing stuff. That was... The perception of that must have changed massively, because that was reserved for the people who were caregivers or who needed it for some reason, I would say, in my generation.
Yeah.
So it must have had a rebrand. The less than full time.
Yeah. In that case, I'm actually really grateful to be where I'm now, because from what I've heard at least, they're a lot more open to it. You don't need to have a child or be taking care of someone. You can just say, this is for my personal development, and most of the time they'll approve it for you.
Wow. So how much less than full time can people go now?
I think I've heard 60%, so 3 days a week as a doctor and then 2 days a week.
So realistically 1 day off, probably.
Yeah, 1 or 2 days off. Yeah,
with all the creep of work and stuff, standard.
Yeah.
But that's really interesting. That's really interesting that most people are doing that. It means we need to train more doctors, but more med school places, etc., etc.
More training spaces, hopefully, as well. But yeah.
Yeah, definitely.
I think even for people who are set on being 100% NHS clinician, I think just being passionate about medicine isn't enough anymore. You have to do stuff alongside, whether that's research, teaching, or leadership, just for portfolio and to get into those highly competitive training spaces.
I was going to say, what's driving that point? So is it that you need to evidence these skills and these things in order to just get along, or is it that you need those to get in high places, or is it that you're scared in some way that the skills as a medic might be not as needed as much in the future and you're trying to protect against that? What drives that for you, do you think?
I think all of the above, to be honest.
Right.
I think if you were just speaking for other people, if you were set on being a doctor, but you want to get into a more competitive specialty in a more competitive region like London or one of the major cities, the competition ratios are insane at the moment.
Really?
So people are taking F3s, F4s, F5s just to develop their portfolio. And these are the people you're going to have to compete against. So
just to get core training?
Yeah.
Wow.
Yeah. It's insane. So being a good doctor is not enough. You have to do research. You have to do teaching at the very least. And if you want to branch out of medicine, which is what I'm aiming for, obviously you have to try and fit in everything else alongside all of that. I still want to get into good specialty. I still want to stay in London, so I have to do teaching. I say I have to do, but I'll really grown to enjoy the research and the teaching alongside it. But it's not something I can choose to stop doing.
It's really interesting. Yeah, I used to love teaching. I used to absolutely love it.
Yeah.
I was gonna make a career out of it at one point. I was gonna try and really go into medical education. Yeah, because I absolutely loved it. I can remember when I was thinking of leaving and I was looking at my options and stuff. One of the jobs that I was gonna take. I eventually went on the FMLM leadership schemes, and that put me at Health Education England, and I sort of went out from there.
Yeah.
But one of the jobs that I interviewed for actually at that point, I actually got the job, but I ended up turning it down. Was a teaching fellow, and I can remember in the interview, they said like, okay, cool, like here's a scenario. What would you do?
Yeah.
And they said, you're in simulation training, and you've made a point, an educational point, and one of your students has put their hand up, they've stood up, and they've basically just completely disagreed with you in quite a seemingly disrespectful way.
All right.
What would you do? And it was super interesting because like my face like lit up, because I'd done a degree in education as well. So my face just lit up, and I was like, that is amazing. And you could see like the panel being like, what is he doing here? Like this guy's out the door. Like this clown hasn't got a clue. I was like, that is amazing to have a student that engaged in the session, that is willing to stand up and defend their point against the authority in the room. I said, that is absolutely incredible. I said, I'd be super proud that I had students that engaged. What I would then do is say, who agrees with them? Who agrees with this person? Put your hands up. And then if anyone agrees, I'd then split the room in half, and then I'd have a debate. And I'd get the textbooks out, and I'd be like, right, now we're all going to find the answer. And the panel were like, oh, that's quite interesting. That's quite different to everyone else's answer, who would like ask him to leave.
Oh my God.
I was like, yeah, look, that's education. That's wonderful, like that kind of thing. So I used to love it, and I absolutely loved it. And it's funny because when so the other day, I put a post on LinkedIn of me as an F1. So I had this like crazy boy band hair that was straightened with like GHD straighteners, like this bright orange stethoscope, and it was like the photo of me and my friend Carf from like being F1s, that the hospital had put on their like intranet or whatever, and I posted it on LinkedIn just saying like, a lot can change in a career. And this guy messaged me being like, oh my God, I think he commented on the post being like, oh my God, you taught me when I was at med school. Wow. You were the F1, I remember you. And I ended up, he's a trainee in London now, so I ended up going to I did a talk on like AI and empathy and stuff to like to all of his fellow trainees and stuff on his training program the other day, which was like absolutely hilarious. But yeah, it's funny. It's funny how people will remember a decent teacher. I think it's a wonderful career to go into, and like an amazing part of medicine that I absolutely love. But tell me about your startup, man. Tell me about, like, I know you're trying to spread your bets and you're doing loads of stuff, research, teaching, like blah blah blah. But like the startup that you're doing, this is great. F1s with ideas, wonderful. Like tell me what it is you wanting to change or wanting to do.
Yeah, of course. So this is sort of a passion project that I started 6 months ago, just over 6 months ago now, with a couple of clinicians. So the problem we're broadly trying to tackle is the massive inefficiency around diagnosing and managing high blood pressure in the UK. So just to give some brief overview of the problem, I mean, there's like 30% of adults in the UK have high blood pressure, so that's 15 million people. 5 million of them are undiagnosed, and another 5 million are diagnosed but uncontrolled. So that's 20% of the population with uncontrolled blood pressure. And we're both clinicians, we know what that means a few years down the line with all the symptoms, these complications that are largely avoidable. So we're trying to make the pathway to diagnosing and managing high blood pressure, we're trying to simplify that pathway, making sure everyone gets a timely diagnosis, and also easing the massive burden on primary care in managing these larger populations.
How? What's the mechanism?
So the main way we're trying to approach it is through improving home blood pressure monitoring. So home blood pressure monitoring is just asking patients to monitor the blood pressure twice a day for 7 days, and then they come back with an average reading. So it sounds very, very simple, which it is very simple. It is very, very simple, but in actual practice, it's not. It's done incredibly, incredibly poorly. So I initially became interested in this idea when I was on a GP placement in medical school. We would see patients that come into clinic with all these high blood pressure symptoms, and then measure the blood pressure, and it's like, 160, 170, and say, yeah, obviously you've got these symptoms. But then we look back and we tell them to go do their home blood reading so we can get an actual diagnosis. But then when we actually look back through the records, we see over the last few years, they've come back with the same problem for multiple times. Every time we've asked them to do this reading, and every time they've not followed up on that. Obviously, there's a lot of reasons, like you just spent 8 minutes trying to find out the cause of the symptom, and now you told them in the last 2 minutes to do some home blood pressure reading. They have no idea how to do it. They don't know what equipment to use. They don't know why it's even important in the first place. So the patient's not educated, and they don't have the motivation to do it. So we're basically building a patient companion app that patients can input their blood pressure remotely and also get access to some high quality educational content to help them along their journey. And then all of this reading is synced remotely to the GP, and the GP can have a massive dashboard with all of the patients under their care. And then they can see 90% of these patients, they have good blood pressure. Okay, add that, automatically track that to the hospital, to the records. We'll follow up again in a year. But for the remaining 10% who have borderline or high blood pressure, then they contact them, bring them in, or do a virtual consultation. Actually spend that 10 minutes, that really precious 10 minutes, trying to find out more about their lifestyle and how they can help manage this high blood pressure, and actually educate them on why it's important, rather than spending 10 minutes trying to read handwriting, strip it down on a piece of paper and calculate an average reading. And that's it.
It's interesting, isn't it? It's back to what we were saying about time. Time to care. Yeah, if you just increase time to care, actually, a lot of problems would be solved, wouldn't they? And I think this thing about like, but what would we do with that time? As Keith Grimes says, clinicians would fill it, and they'd fill it with stuff that's very useful. So you don't need to fill that time. Don't worry about it. We will make the healthcare system better. Just give us more time.
Yeah.
It's really interesting. Come on. So the other thing I think as well, like, so that what reminded me, what jumped into my head when you were talking was, it's like a public health job, isn't it, of like a changing culture, because we wear like Oura rings and Apple Watches for heart rate variability and that kind of thing. And I know it's a certain type of probably the healthy population that do that, and certainly the wealthy population that do that. Yeah. And there are people that these devices leave behind who end up actually being the problems. I know that's the case.
Yeah.
But it's interesting that it would be an interesting change in culture that blood pressure was one of those things that we all just became very aware of, in the same way that we get an eye test, in the same way that we get a hearing test, and we go to the dentist. All these things that we know that we need to do an active job of prevention on. There isn't a similar kind of equivalent that everybody, like, as much as everyone goes to the dentist, there's not a similar kind of health MOT that looks at things like blood pressure. Yeah. And it's interesting, isn't it? Because the blood pressure is going to be a bit more of an issue than some tooth issues, or my dentist seems to want to charge me for literally everything at the minute. So like that, or an eye test, or whatever it is, like it's funny that doesn't come into zeitgeist. But the other thing that it reminded me of, I don't know if you've seen at the minute, this Brian Johnson guy. I think it's Brian Johnson. You know, the guy that's like trying to live forever.
Yeah.
Yeah.
I fell down into that rabbit hole.
He's been on a lot of stuff recently. He's clearly doing like a media push and stuff. And he said some really interesting things. Like I saw a video the other day where he was talking about, people are really disrespectful when they talk about me. They say like billionaire or vampire, or he looks like this, or he's trying to do that. And he's like, what I'm really trying to do is push the limits of humankind. I'm putting my own hand in my pocket. I'm not hurting anyone. Like, why is everyone so like horrible to me? I was actually when he said that, I was actually just a bit like, do you know what? I don't know about this guy. I don't know how he made his money. I don't know about any of that stuff. I've got no right to be disrespectful to this guy, at all. And he's got a point, because what he was saying is, people don't, and I'm paraphrasing and I might be butchering this, but he's saying that, and I think his point is that if he experiments on himself, he's paying 2 million quid a year, I think, reported, on his own health, just to keep all of this stuff going. He's like, if I can redefine what optimal health looks like, then isn't that a good thing for humankind, that actually I start noticing this stuff? And that jumped into my head, I think, because let's say that, Brian Johnson ends up saying, like, at the end of the day, you need these 4 things to be, like, on point, and number 4 is just track your blood pressure. All of a sudden, you're like, well, actually, he's got a lot of context. Like, you can literally see the context, because you see him playing out his entire life. Like, and he's like, okay, the canary in the coal mine of most things is blood pressure. So actually, if you keep that down, number needed to treat super low. So actually, we all should be better off just doing like a quarterly blood test reading on ourselves, or average blood test. Like that ends up changing culture. And I just think that stuff's really interesting, because what he has ended up saying is things like, if you're going to do one thing, sleep. If you're going to do another thing, exercise. It's like the things that we do already know those things. But I wonder what numbers 8, 9, 10, 11 are on that list, that we could all just be a bit more like on it. One of them might indeed be blood pressure. That's the kind of stuff that that jumped into my mind. My question for you though, mate, is, so super interesting. What are your goals with this? What are you trying to achieve with it?
That's a very good question. It's still something I'm trying to figure out. I think the 3 of us are all clinicians, so we went into it wanting to improve public health, to put it simply, and that's our main goal. So we're also trying to think about, once we've solved the, in quotation marks, blood pressure, where else can we go next? So that's the rest of cardiovascular health, which we all know is a massive priority for the country. So. Indeed. We don't really have a grand vision. We're taking it one step at a time, but we want to target things that are, like you said, quite high on the priority list and quite low numbers needed to treat. Things that we can tackle with the existing technology, or by changing up, or by improving the clinical workflow. Things that we can have an effect on now and make a big enough impact. And that's our primary goal.
It's really interesting. I think what I would say is, when you're looking to solve this problem, then what other problems could I solve? I think it's a life's work trying to solve more people getting a blood pressure check. That probably won't be solved in your career or lifetime. So actually, it's funny, because you pick off the early stuff in a project like this. You'd pick off the early stuff, and you'd get these quick wins, and it all feels great. And then you run into the actual problem of why this doesn't work nationally, or why aren't I able to get everyone to do this? Why can't I actually put a dent in the thing? That is the problem to solve, and it's interesting, because then you think globally, and then you think this, and they think that, like that then becomes super interesting. And I think what I see a lot, and do you know what? You can do it either way. You can follow your interests and just stay interested and stay alert and sharp, and you can superficially solve a lot of problems. Or you could solve one problem very, very, very deeply, which may or may not be more or less satisfying than the other. I know it's harder. I know it's definitely harder to actually fully solve a problem, and especially in a world where public health, I think, is poorly done now, if I was to say it. I've spoken to enough healthcare influencers at the minute to know that basically them and YouTube Health are probably the new Public Health England, and they're doing everything they can to produce more health content, and actually that's a bit of a business model that works. I just wonder, like, if you guys were to ask yourselves the questions, how would we actually solve this problem, like, in a meaningful way nationally? How could we be known as the people that genuinely put this on people's radars? I think then you start getting into some really, really, really interesting stuff. And it's funny, because that's where it turns from a project into a business, arguably, or that's where it turns into a social enterprise, or it turns into a community interest thing, or it turns into like, there's loads of ways. But then it's interesting because you go, hold on a minute, what's the yes if? Okay, yes, we could do this if we had £5 million to spend on blah, which is obviously ridiculous. Well, no, it's not, because now you have a business model. I need £5 million to do blah, and blah is going to return loads of like profit and impact and blah, blah. Then you've got then there's a need to start a company, because then with a company you can then take that 5 million into something and you can spend it and all that. So it's interesting thinking about it in those terms, but ultimately as well, like, you've got to just stay interested as a clinician. And I think if it's wanting to solve the problem for a small population or one site or whatever that uses this stuff, great. But if it's an initiative that works, man, I think there is no ceiling, and don't let anyone tell you that there is.
I think there's quite a lot of interesting things I'd like to reflect on what you just said. So firstly, like, everyone that we've spoken with about this idea, they all agree it's got massive potential, and it's something that's desperately needed. But then you start thinking, like you said, why hasn't it been done before? Like, what are the roadblocks we're gonna face? I think we've got a couple of pilot studies that are starting soon, and I think after we've run those, we're gonna start facing those roadblocks. And that's
what are you trying to prove in the pilot studies?
So we're just quite a few things actually. So firstly, we can improve patient outcomes with obviously the pilot studies are quite short term, so that's just improving the percentage of the population with the blood pressure control. But over the long term, ideally, we'd be looking at the more important cardiovascular outcomes. Also, improving the efficiency for GP practices. So reduce. I think
now you're talking.
Yeah, I think we did a survey when we first started, and it was one of my co-founders is a GP who works for a few practices, and in the practices he works at, everyone was spending 200-300 minutes a week per practice on single blood pressure readings, and those readings don't mean anything because they're single readings. So then they get told,
white coat, etc.
So then we run into the same problem. They get told to go home to measure the blood pressure. They get lost to follow up, and the cycle repeats over and over again. So it's just that 200-300 minutes. Imagine you can, even if it's 10 minutes per appointment, a GP can educate 20-30 people every single week on.
Well, that's it. And instead of appointments for it, you just send the guidance to do it at home. And you get the readings sent in, and then it's managed in an admin capacity, and actually it just goes off the... amazing.
So that's what we're trying to prove in the pilot studies. But I think there's a roadblock that comes next. That's what really excites me. Like you said, why isn't this still more? Why hasn't this been done before? Why hasn't this scaled successfully? From speaking to a few people in the space, there's a lot of companies have tried to do something similar. I think Omron is quite a big one that I've got a study at a handful of GP practices in Northwest London. But from speaking to them, some of them tried Omron. They similarly have a blood pressure app for patients to then send off their readings. But what they haven't figured out is the actual clinical workflow, because now we have thousands more people sending in normal blood pressure readings, and the GP is spending hours and hours manually saying, oh, this reading is normal, I have to code this into the EHR, and then decide what to do from that. So you've solved one part of the journey, but the workflow itself, you've now created more problems. So that also links back. The final thing we're trying to solve with this pilot study is how can we redefine the workflow? Like, what's the ideal patient journey? What's the ideal clinician journey for managing blood pressure at a population level? I think it's that sort of question that excites me the most.
Yes. You should have opened with that, man. This is the dream. If you're saving that amount of time for GP practices, you got a business model, mate. Yeah. That's absolutely ideal. But yeah, there is obviously this way to come at it.
Yeah.
I just wonder as well whether it's a public health problem of blood pressure at home is so unbelievably cheap to just get a device. People, the population of the UK knows more about heart rate variability than they need to. This is some random metric that everyone seems absolutely obsessed with at the minute. Like, and if the public has the ability to learn about heart rate variability, they have the ability to learn about two numbers, one on top of another, and like what number to keep them under. So otherwise they need to do something. I just wonder if an arm of what you do is, even if it's a local initiative, to just monitor it at home. I mean, I can see it now. I mean, with my comms hat on, I can see it now, like a national campaign. That you do some really cool TV ads that's like, just measure your blood pressure at home. Like all this complicated stuff that you could do with your health. And it's like, just monitor your blood pressure at home. Like that's literally going to solve most of your problems. Rather than your imaginary problems, it's going to solve an actual problem. And it's, I just wonder if an arm of what you do is like that education piece to like, just don't even come in the first place. And like, then the amount of dropped appointments or appointments you no longer have compared to control and that sort of stuff. I think that, but again, I'm biased because I'm in communications and I love public health and all that sort of stuff, where that is where my mind goes. But I think it is. I think it's a very fascinating problem to solve. What do you think? I mean, you mentioned obviously the challenge of like scaling and stuff, but like what are the challenges for you as an F1, as an F1 trying to do another project and just trying to make this relatable, I guess, to similar people in a similar situation that would love to have an idea or do something but don't feel they've got enough time, like what or whatever it is. But like what are the challenges for you, like right now, in terms of all this stuff you're trying to balance?
I mean, the simple answer is just time. You're working 45 hours a week, you're doing research and teaching on the side, and then on top of that you're trying to find time to build a startup, and you're trying to, and you ideally still want to have time to have a social life and have some hobbies. I think that's probably...
How dare you as a doctor? You're exactly. A doctor now. You're a doctor now. You don't have hobbies. You don't have a personality.
Yeah, it does feel like that somewhat time. But I think that's definitely the biggest challenge, trying to find time for all of these. But at the same time, it's possible. I definitely say it's possible. It's difficult, but it's a big challenge to have these sort of different interests. I think if I were to be just doing medicine, I would get burnt out on it quite easily. But it's because I'm doing all of these things that some might say balancing too much is a recipe for burnout. But from my perspective, it's all of these have sort of a reciprocal relationship. So the more interested I get in the health tech sphere, the more interested I get in actually seeing patients in my clinical practice. And the more patients I see, the more I understand their problem, the more I understand what's needed to change. So all of these interests build on each other, which I think is why I'm really enjoying that portfolio aspect.
I love what you've just said, mate. I think that is wonderful, because I feel exactly the same at the minute. Because building a company and building a bootstrapped company that's like profitable from day one. I don't mean that as a flex. I mean that as like, you've got to make profit all the time. So you've got to spend less than you earn each month.
Yeah.
And obviously with varying clients coming up and down and all this sort of stuff, and staff that stays relatively the same, you kind of have to like the cyclical nature of revenue means that there are these moments in the year where you're like, should we going to be profitable? Are we not? Like, how long can we not be if we get there? And like, okay, it's all fine again because we've got big contracts. Like, there's a lot of stress that comes along with that.
Yeah.
But it's interesting because at the minute, like, I've got an 8-week-old son who's like my first child. I've got this like new community thing, this idea that I've had that I put out the other day, like the next generation community. And I feel like the stress that I'm feeling on the sort of normal company side, I'm going to use the word like diluted. It's the stress is diluted because I've just got other things going on in my life, and it's like I've got that. Like I play tennis a couple of times a week, so I play matches and stuff. So when you've got more pillars holding up your mental fitness, I'll just call it.
Yeah.
For me, that's better. It's actually when let's say I get injured and I can't play tennis or go to the gym for a while, and at the same time, like, I'm not really learning anything new. I've got no learning skills going on or whatever. And then something bad happens at work, and all my energy needs to go on. That's just the worst. Like, that's the absolute worst. But if
completely agreed.
If there's work challenges, but I've got a tennis match at the weekend, and I've got to take my son to have his injections, and I've got to. You start to put, like, there's a lot more context, isn't there? And you're absolutely right. These things build upon each other, and I think particularly like this next generation community idea that I've had, like, putting that LinkedIn post out, expecting 10 people maybe. I was like optimistic. I was like 10 people are going to comment on this, like, and they'll just be the committee.
Yeah.
Oh my God, like 1,000 people have, like, got in touch with me one way or another, like, because it's clearly like a big need, and it's just it's weird because it's more work for me to do, but it's taking the pressure off.
Yeah.
Like, it's such a bizarre thing, and I think that's I think that's the thing about burnout, is that I think you burn out doing work that doesn't fulfill you.
Yeah.
But then there's like it's almost like antimatter. When you do work that does fulfill you, it's like antimatter to, like, the other thing. Like, it actually it sort of it more than evens it out, if you know what I mean. So you take energy from it, even though it's giving you work, like you said.
Yeah, completely agree.
Which I think it's fascinating. I think that probably points to, like, the entrepreneur in you, maybe, because I think solving maybe it's just everyone, like, solving problems is energizing for me massively. And when I solve a problem in industry, like, wow, like, that's amazing. Like, dude, that post, like, seeing just how needed this was, not only validated me thinking, like, okay, I do actually know what the sector needs. Like, I am good at paying attention. Like, okay, good. I have got to something first again. Like, good. Okay, I've still got it. Now I can build this thing, and it'll be cool, and it'll be great, and, like, all that sort of stuff. I'm just taking so much energy from it. It's awesome.
Yeah, like you said, that post completely blew up. It's like so many comments. I can't even imagine the number of DMs you must have gotten. I'm not sure if, like,
it's over 250 at this point.
Yeah.
I'm
not sure if you want to give us a little sneak peek into what you're planning with that.
Yeah, man, good question. So, well, basically, I'll tell you a story. So I was, my friend Andy, who I've known from university, so coming up on 20 years I've known Andy. We went, he's emigrating to Australia, and we went for, like, just this, like, day in London, basically. So, like, just went and did some stupid stuff in London like we used to, and just had, like, one of those days where we, like, forget all our responsibilities and just, like, let's just be 20-year-olds again and, like, have some fun. And it was, like, super fun, like, so nice.
That's so
but
good.
Obviously Andy's in the energy industry, he's in clean tech, and so he basically, when he was super early in his career, so first few years his career, worked for this place called the Energy Institute, and they had in their newsletter just this line in their newsletter, and he was telling me this on our sort of day out. They had this line in their newsletter which was like, if you're a young professional and you're super interested in the space and you want to be a future leader, come to this place at this time. And he was saying, and I'm going to butcher this, but, like, inserting facts here where they might be pseudo facts, but he was like, 4 or 5 people turned up, and he was one of them. And they basically said, like, cool, you guys are the next YPN committee, the Young Professionals Network. You guys are the next Young Professionals Network. Here's a couple of grand. Go and run some events through the year. If you can, make them profitable. And that is now in 15 countries. Because it gives a voice to the young professionals who are craving leadership, who are craving events of the things that matter to them. And Andy was basically saying, like, it's amazing because he now sits on the council, which is above the committee, that helps the committee. And he was saying it's amazing because you can think you know an industry until you ask the people who had no voice to come up with the themes and the topics and the questions. And he said it's a consistent source of joy when they come up with an idea for an event around a topic that he had absolutely no idea was a problem or an issue or an opportunity or a thought or whatever it is. And then going to those events and like hearing what the young people have got to say and young leaders have got to say, inspiring the members who are also young leaders in their organizations and spaces. And he said it just helps the industry go forwards. Yeah. And so I was listening to this just being like incredibly inspired. He obviously then finishes with like, you should do this in health tech. And I was like, I don't know if I've got enough gravitas, man. Like I don't know if I've got like the ability to pull all that together, but I tell you what, we'll give it a go. Like here's what I'll do, sort of thing. And he was telling me like super practically like how it works. It's like you've got a committee which has 5 officers which are more senior, so they've got 3 years of experience in industry or in a job. Right. And then you've got a junior committee. Right. The junior committee members who are less than 3 years experienced in their job, so they're learning from the officers. But then you've got the council who sits above them who just give advice. But basically you give some money to the committee, they go and run events, super hands off. Like you meet with them 4 times a year, teach them how to do board meetings basically, and they get a massive learning experience. They get money to play with, they get to put on events, but they've got to make it profitable because otherwise it can't continue for next year. So they've got to leave the same amount of money that they inherited. So they got to do something. They got to make the events break even. They got to make them profitable. The really good committees will make them super profitable. And then you've got a big war chest and all this sort of stuff. But he said over the course of 12 years, like it's just been amazing to watch and like all this sort of stuff. So that's the vibe. So I don't plan to reinvent the wheel. I don't plan to own it either. Like I just think this should be a community owned thing where I'll chair the council for the first term. If I'm re-elected, great. If not, even better, because it's got a mind and a life of its own. But I'll chair the council. I will basically now search through all of these people, add everyone onto a Substack, so it becomes a newsletter that makes you a member for now. It might be more in depth later, but then we can find out who wants to be on the committee. We can run a poll for votes for whoever the members want to vote on the committee. We'll elect the committee, and then I'm just going to let the thing fly. I'm just going to absolutely let it fly and see what happens, and hopefully we elect a good committee, or hopefully the members elect a good committee. Because seemingly like everyone was just so keen to join it, dude. Like I don't know if you want to explain it from your position, like because I know we chatted about it before, but I just think it's hard being early in your career with the desire to change things and like not having a voice. Because I don't know about you, but seeing the same people saying the same things on LinkedIn, probably me being one of them, like especially these like 15 tips of do blah and like 5 traits of a bad boss. I'm like, oh my God, like really, is this where we're at? And I know that the young professionals are looking at this being like, we're AI natives. We know exactly what you've done here. Like this is not going to fly in the next 5 years. Yeah. So I want to be on the side of the right side of history. Let's say I want to be on the side of the future. I don't want to be, because I was thinking the other day, I was like, oh, maybe I should. And I was like, slap myself in the face. Like, absolutely not. Like, to stop that. No, everything of value. You've got to be better than this. And so I literally just challenged myself, and I was just like, I just need a new idea here. This needs to be put in the bin. And I was like, I think this is it. And if we do need a social network of our own, the Peer Boys, Abdul, etc., we'll host the whole thing on Peer and just we'll leave 15 traits of bad bosses to the side. Yeah, that's the vibe, man. But I don't know what, like, obviously you're early in health tech. I know there's the BMJ Future Health event as well. And I think actually part of this is like wanting to affiliate with the things that I know are going to keep providing that sort of value and access to becoming the future leader you want to be, like that BMJ Future Health event or like other stuff that's going on. But yeah, man, like, I don't know. Does it resonate?
Yeah, I think I'm like,
you have to say that. No, I hate it.
No, I'm gonna stand up and be like completely no. But I think I come at this from a few different perspectives. Firstly, being someone who's, like you said, a young professional, relatively new to the health tech space, still trying to figure out what I want to do in it and looking for a voice even. I think that from that perspective, this committee, whatever events this committee is gonna put on, is gonna be a must go for someone like me.
That's so nice to hear. That's so cool.
Like, I completely agree. People have said, like, I've worked for a few health tech companies, and people have said they want to build a next generation committee. They want to build a young professional committee, whatever they want to call it. But in the end, these people, all they do is provide some feedback in an already very crowded room. And in the end, who are the companies going to listen to? Someone who's just starting the health tech, or someone who has 20 years of experience. So that all of their voices do get drowned out for best, like, obvious, and being able to see what the young people, what they build themselves, I think that is going to be really, really exciting, and completely agree. I can't wait to see what sort of event. I can't even imagine what sort of events they want to put on. But
neither can I.
Yeah.
Neither can I. Like, what experimental, like, weird shit they're gonna do. Like,
yeah.
It'll be, or just what we do now, just with better people. Well, I say better people, but, like, you know, new people, fresh ideas, fresh people. I think. Yeah, it will be very cool, because it's interesting what you say as well about, you know, people have tried it and it hasn't worked as well. Like, what I see at the minute is, I think we are craving community. We have been for a while. I think when I was a young professional, I feel as young as that. I can remember my first day, but I'm not a young professional anymore. But I can remember it. It was a lot easier. There was a lot more serendipity, I think, in the world, is the way I perceive it, because we would do a lot together. I know medicine is actually, you know, one of the careers that is preserving you must come to the office every day. You can't quite do it from home unless you're a telemedicine GP, I guess.
Radiologist.
Or perhaps doing a remote online clinic, which you probably do from the hospital anyway. So you pretty much have to be in the hospital for most things as a doctor or any other clinician. But yeah, there's much more serendipity in the world, I think, because it was far more common to be out and about and drinks after work and all these things that obviously have their own problems. But, like, I do recall loads of, like, meetup.com was the thing. There was loads of, like, tech meetups that you could pretty much go to one every day. And I used to go to the ones that weren't healthcare. And I used to be the only person in healthcare listening to this, like, Java thing about, and I didn't really understand most of it. Or I'd go to, but that would be, like, my USP. It would make me feel, like, interested to be there rather than just one of the crowd. So I'd, like, try and, like, go to all this, like, interesting stuff, and you'd get into some really interesting conversation. It just expanded my mind a bit. And I don't think that stuff is as readily available or as commonly done now. And so the serendipity of all of that, and I do these, like, little projects with people, or even just talk about them for a little bit with certain people, it would just spark so much, and you'd get introduced to people, and I just think we're missing out on that. And I think one of the principles of it is actually what I've just talked about, in that, you know, why bundle health tech and biotech? And it's like, well, when I think of the company that I've built, we serve health tech and biotech companies because it's the same expertise, like, broadly. And I'm talking broadly, like, you hire scientists and creatives, and those scientists are as interested in health tech as they are in biotech. It can be a fluid ecosystem. And yes, there are certain niches and specificity in biotech and all the rest of it. But actually, like, those groups of people are interested in the same things. Like, they're interested in turning science into better human health. And so we have more of a strength. You have more of a strength in numbers. And I thought, like, should I do next gen health tech and next gen biotech? Should I split them? Should we do da? And I'm like, what's the point? Like, everything's better, and actually it's far less risky if you've got a bigger pool of people to. I was like, at least I can probably get, like, 50 people to turn up to an event if it's, like, both. Like, I could probably get 25 from each community, so there's a bit less risk in there. But I actually just think the whole thing just is a bit more interesting, frankly, like, if you just bundle everyone together. And so it's basically just people doing science, innovation, and technology for human health, which I think is just awesome. So, like, it's trying to just create a lot more of that serendipity, I think, of a few more disparate, like, professions and niches and, like, academia and, like, all this sort of stuff. So Yeah,
I think
those are the vibes. Those are the vibes, man. We'll see how it goes. We'll see how it goes, because we're speaking on the 12th of February here, which is literally like 3 days after I posted that thing. I'm gonna put that out. As I said, I'm gonna literally reply to every single person and be like, please join the Substack. It makes you a member, and then you can vote on the committee, or you could apply to be on the committee. And I'm going to say as like literally everyone that's DM'd me, at least.
That's going to be a whole week of replies.
And just see. I think it will be, but like it's worth it. Here's a tip, man, that I've learned from someone on this podcast. I think it was Asif from MedShare, probably in like 5, 6, 7 years ago. Your first 1,000 users, you get however you can, and it is blood, sweat and tears, and it's most likely one by one. Your first 1,000 anything is probably one by one, and it's going to be painful. And so don't fall into the trap of ever thinking that you're too big time for literal messaging people one-on-one. So I certainly take nothing for granted, especially when you're trying to set up a new thing. But yeah, I also think as well, like, a lot of these communities start with like a very thinly veiled like self-interest. I hope at least I've veiled it a bit harder, or people do actually believe that largely I am just trying to solve a problem for the space here, because I've just got no interest in making money off this, because I think that literally kills the vibe.
I think
there's just I don't think there's any point. Like what are you gonna you pocket some of the sponsorship when you could have just made the events loads better? Like, I don't know, it shouldn't be worth it. I don't think that stuff.
I think like by just how you phrased it now, by giving complete control to the committee, I think that act in itself shows how much trust you have in these people, and that
I was the future once, etc.
Yeah. And I think that in itself really shows that it's not just about making a profit. Like you said, you could probably run the events yourself much better, much bigger, but the idea isn't to make a profit. The idea is to give voice, and by actually giving these people voice, giving these people an opportunity, I think that really reflects on your personal values, which I really, really appreciate. I think,
well, thanks, man.
I think I probably speak on behalf of the 1,000 people that reply to your LinkedIn post.
Well, thank you. I appreciate that, and I look forward to it. The anarchist in me just wants to just see like something super weird come out of it.
Yeah, me too. Yeah, it's just exciting.
Yeah, it is. Yeah, it is. It also could fail, and I think that's okay. I think the other thing as well is that I'm sort of drafting the newsletter now, and I've just put like a tongue-in-cheek thing at the end of like, this is a very public how to or how not to put a next gen committee together for an industry. So either way, we'll consider this as a win or good learning. So, like,
we'll learn either way. Learn by example or learn by failure.
Precisely. I've done the sector a favor by showing you how to do it or how not to do it. And if it's how not to do it, then the next person can come along and do it properly. Listen, Tom, absolute pleasure speaking to you, man. This has absolutely flown by.
You too, yeah.
We've covered a lot of ground here. If people want to get in touch with you, man, if they want to learn more about the startup, if they want to learn more about getting through medical school or applying for F1, any tips on beating the lottery in the F1 thing? What's the best way for people to get in touch with you?
Yeah, LinkedIn is probably the best way. I'm pretty good at, I say I'm pretty good at replying to messages, but yeah, very happy. Like I said multiple times, I'm still very early in this journey, so I'm just hoping to learn from you guys if you guys want to get in touch as well. Very happy to share any thoughts I have as well. But yeah,
beautiful.
Absolute pleasure speaking with you, James.
You're very welcome, Tom. See you soon.
See you soon.